Hello everyone. Our topic of discussion is anaphylaxis. But before I go on to define what anaphylaxis is, I would have to first mention what allergic reactions are. So allergic reactions are sensitivities to substances called allergens that come into contact with the skin. It can be the nose, the eyes, the respiratory tract, and the gastrointestinal tract. So these substances can either be ingested or they can be injected or they can be inhaled through the lungs. So in an allergic reaction, what simply happens is that the immune system starts fighting substances that are usually harmless, as though these substances were trying to attack the body. So many allergic reactions are mild, while others can be severe and life-threatening. So anaphylaxis is simply a sudden severe allergic reaction that can be life-threatening. It is a medical emergency case. So it can occur within seconds or minutes of exposure to something someone is allergic to. And anaphylaxis, in other definitions, can be described as an acute multisystem severe type 1 hypersensitivity reaction, which can be characterized by cardiovascular collapse, bronchospasm, and skin changes. So it comes from a Greek word of which ana means against and phylaxis means protection. So here just is a grammatic representation of the types or classifications of hypersensitivities. We have type 1, which is immunoglobulin E mediated, or it's at times called classic allergy or true anaphylaxis. We have type 2, which is pseudo anaphylaxis or non-immunoglobulin E mediated. It's mediated by immunoglobulin G and immunoglobulin M. We have type 3 and type 4 as well, but our main concern of today's discussion will just be more biased to type 1 and type 2. So what simply happens in an anaphylactic reaction is that the patient would have had a previous exposure to an allergen. So when he or she is re-exposed to the same allergen again, so because of the new challenge, an immunoglobulin E mediated antigen antibody reaction takes place, and mediator chemical substances are released from the mast cells and basophils, which act on the skin and mucous membrane to produce severe vasodilatation, leading to cardiovascular collapse, bronchospasms, urticaria, itch, edema, etc., etc. Anaphylactic shock is just simply anaphylaxis associated with system vasodilatation, which results in low blood pressure. The two types of anaphylaxis of which I mentioned earlier, of course, type 1, which is immunoglobulin E mediated, the true anaphylaxis or classical anaphylaxis. Type 2 is at times called pseudo anaphylaxis or anaphylactoid reaction, which is non-immunoglobulin E mediated. Okay, so the pathophysiology was mentioned earlier. Of course, when the mediators on re-exposure, the antigen binds to the antibody and the receptors are activated. Clinical manifestations result from release of immune response mediators such as the histamines, leukotrienes, tryptase, and prostaglandins. So here are just a few pathological processes of which the signs and symptoms are as well described and the mediators responsible. So when we talk of vasodilatation, so urticaria, clinical signs and symptoms would be urticaria, angioedema, rhanjoedema, of which the mediators responsible for that are histamine 1, the leukotrienes, and prostaglandins. Okay, then we have vascular permeability as a pathological process. Signs and symptoms would be flushing, headaches. Okay, and the mediators responsible are mentioned. The smooth muscle contraction would be a clinical sign and symptoms of wheezing, gastrointestinal cramps, diarrhea, and the histamines, of course, are responsible for that congestion. Yes, so When we talk of the pseudo-anaphylaxis or anaphylactoid reaction, so this one, like earlier mentioned, is not immunoglobulin E mediated. What simply happens is that there is no sensitization by previous exposure. Here the substances directly act on the mast cells to liberate the histamines. So what are some of the causes of anaphylaxis? So, like we just mentioned, anaphylaxis can occur in response to almost any foreign substance. But some of the most common causes of anaphylactic shock are certain medications. These can be penicillins, it can be ampho-B, the NSAIDs, it can be the cephalosporins, the angiotensin converting enzyme inhibitors. Some of the other causes would be latex allergy, where one uses gloves or other latex products. The other commonest cause would be foods such as peanuts, milk, eggs, fish. Thirdly, it can be as well as insect stings from bees, wasps, ants. Then the least common causes of anaphylaxis include exercises, often after eating certain foods. So anaphylaxis usually happens within minutes of exposure and almost always within 2 hours. What are some of the risk factors of anaphylaxis? So some of the commonest risk factors would be a personal history of anaphylaxis. So if you've experienced anaphylaxis once, you're at risk of having this serious reaction. Your risk of having this serious reaction is increased. Future reactions may be more severe than the first one. So the second risk factor would be allergies or asthma. So people who have either conditions are at risk of having anaphylaxis. Thirdly would be a family history. So if you have family members who have experienced exercise-induced anaphylaxis, your risk of developing this type of anaphylaxis is higher than it is for someone without a family history. So what are some of the signs and symptoms of anaphylaxis? So the commonest area that is affected is the skin, which is about 80 to 90%. Second would be the respiratory tract with about 70%. The GIT with 30 to 45. Then we have the heart and vasculature. We have the central nervous system, the CNS. So these symptoms usually develop over minutes to hours. So with this illustration, so some of the signs and symptoms that would present through the CNS are lightheadedness, can be muscle spasms, or of course muscular weakness. It can be confusion, headache, anxiety. The respiratory tract would present signs and symptoms of shortness of breath, wheezes, hoarseness of the voice, pain with swallowing, as well as cough. The GIT, crampy abdomen, pain, diarrhea, vomiting. Okay, would notice or see loss of bladder control, pelvic pain, the skin, of course, hives, itchiness, flushing, and with heart and vasculature, there would be fast and slow heart rate, low blood pressure, like we had described in anaphylactic shock. Then the lips, of course, would swell. There would be swelling of the lips as one of the signs and symptoms. The tongue as well would swell, and the throat. Yes, so with the eyes, you'd notice swelling of the conjunctiva and also the running nose. So what investigations are done to confirm anaphylaxis or allergic reactions? So allergy testing is ordered to help in determining the trigger. Skin allergy testing, such as patch testing, is available for certain foods and venoms. Blood testing for specific immunoglobulin E can be used to confirm milk, egg, peanut, tree nut, and fish allergies. Diagnosis. Anaphylaxis is diagnosed based on clinical criteria. When any one of the following three occurs within minutes or hours of exposure to an allergen, there is a high likelihood of anaphylaxis. So 1. Involvement of the skin or mucosal tissue plus either respiratory difficulty or hypotension. Secondly, 2 or more of the following symptoms. So it can be involvement of the skin or mucosa, or it can be the respiratory difficulties, or it could be low blood pressure or gastrointestinal symptoms. Thirdly, so low blood pressure after exposure to a known allergen. Treatment. How is anaphylaxis treated? So like we had described what anaphylaxis is, we said it's a medical emergency. As such, its mainstay of treatment is as follows. So if this drug is a known trigger of anaphylaxis, there has to be a stop of further administration of that drug, because we mentioned to say one of the commonest causes of anaphylaxis could be drugs, and we gave examples of such. The other, in terms of treatment, the mainstay of treatment, of course, we have adrenaline or ephedrine, also known as ephedrine. Okay, so epinephrine, not ephedrine, so adrenaline or epinephrine. Secondary, IV fluids. Thirdly, maintenance of the airway. Fourth, oxygen therapy. 5, the use of, we'll discuss about the use of antihistamines and steroids. So 6, we have bronchodilators. Okay, then 7th, we have IPPVs if respiratory failure and others occur. So during treatment of anaphylaxis, anaphylactic reaction or anaphylactic attack, CPR may be performed on a patient if the patient stops breathing or if the heart stops beating. So about adrenaline or epinephrine. So these are epinephrine. We know that it's an adrenergic agonist, or it belongs to a class of what we call the sympathomimetics. So through its action on the beta adrenergic receptors, epinephrine leads to the bronchial smooth muscle relaxation that helps to relieve bronchospasm, the wheeziness, and difficulty in breathing that may occur during anaphylaxis. Adrenaline has a strong vasodilator action through its alpha adrenergic stimulation. This activity counteracts the vasodilatation and increases vascular permeability, leading to loss of intravascular fluid and subsequent hypotension in anaphylactic shock. The dosage, of course, it's given at 1 milligram per kg body weight as a bolus IV. Yes, as diluted solution, repeated up to about 1 milligram. So here we're told to say never give an diluted adrenaline IV. So it can be given either intramuscular, subcutaneous, or intraosseous, or intratracheal. So here it's just simply the dosage at which it's given, 0.01 milligram per kg body weight, maximum daily dose of, that's in patients of any age. It can go to a maximum dose of 0.5 milligrams per single dose. Okay. So here the other thing that is being mentioned about fluids that can be given. So both crystalloids and choroids are administered very fast to make up for the volume deficit. That is in those in anaphylactic shock where one is experiencing hypotension. So it may be given up to about 2 liters or 25% of the blood volume. So with children, 20 ml per kg body weight over 15 to 20 minutes period, which can be repeated if needed, up to about 100 ml per kg body weight if required. So the histamines. So in terms of treatment with with antihistamines, so relief of hives and itch. These medications, one thing that we should know is that they do not relieve upper and lower airway obstruction, hypotension, or shock, and in standard doses do not inhibit mediator release from mast cells or basophils. So any first generation only first generation antihistamines. So only first generation antihistamines are available in parenteral formulation, and rapid IV administration may increase hypotension. So those some of the commonest two that we know, like first generation antihistamines that are available IV, diphenhydramine as well as promethazine. So the steroids, the glucocorticosteroids, we have hydrocortisone, prednisolone or methylprednisolone. So these are usually, it is not clinically proven though. So the prophylactic use of these substances are of doubtful value. Bronchodilators. So for the treatment of bronchospasms not responsive to epinephrine, inhaled bronchodilators such as salbutamol or butylo should be administered by mouthpiece or face mask for those whose age or condition requires, and nebulizer or compressors as needed. So aminophylline as an infusion is there for bronchospasm, which is given at 250 milligrams in 500 ml or 5% dextrose. So bronchodilators are adjunctive treatments to epinephrine because they do not prevent or relieve muscular edema in the upper airway or shock, for which the alpha-1 adrenergic effect of epinephrine is required. So what are some of the complications of anaphylaxis? So some of the complications would include pulmonary edema, pulmonary hemorrhage, and pneumothorax. So laryngeal edema with or without airway obstruction can occur. Myocardial ischemia and infarction may occur. Death actually may result from asphyxiation, from upper airway obstruction, or profound shock, or both. So here, just something being mentioned of about refractory anaphylaxis. So anaphylactic shock displays features of both distributive, or which we are referring to as vasodilatory, and hypovolumetric shock. So further management would involve like shifting to ICU and treat shock as per protocol. So norepinephrine, vasopressin, dopamine, and other vasopressors have been used with success in patients in anaphylaxis with refractory hypotension. So that is all about anaphylaxis for this presentation. Thank you.